Hello, this is Sudharshan, and in this episode PA 28.16, we will talk about urothelial tumors or bladder cancers. So, in this urothelial tumors, the most common one is transitional cell carcinoma. So, this is a cancer that affects the transitional epithelium, that is the lining epithelium of the bladder. And most common cause is P53 mutation. And there are two theories that will suggest field effect and implantation theory. So field effect, that is nothing but if the tumor is there in a particular area of the transitional cell, it can break off and then move along the fluid, that is the urine. And implantation theory, that is where the tumor cells will be attached in different sites. So these are the two important theories. And risk factors, for this there is a mnemonic, that is PSAC. P for phenacetin, S for smoking, A for aniline dyes, and C for cyclophosphamide. This is very important, mostly cyclophosphamide. It causes hemorrhagic cystitis, that is the bladder infection with bloody discharge also, because the surrounding vessels are also affected. So the tumor is invasive, so it can spread to various sites. And when it comes to clinical features, most important, painless hematuria. That means blood is there in the urine, and while the discharge is happening, there is no pain. And there is flank pain, that is a region between the thoracic wall and the pubis. And then also it can be above that or suprapubic, it can be perineal or abdominal, anywhere. It can lead to dysuria, difficulty in urination also. Right. And with respect to the diagnosis, cystoscopy can be done to detect the presence of tumors which is there. And labs also we can do to see we'll do a urine analysis and culture. If any infection is there also, we can identify. And with respect to the treatment, surgery with chemotherapy and radiation therapy. And briefly with respect to gross and microscopy. So grossly, how is the tumor? If we can see, so we can see that the tumor is in one particular area of the transitional cell, and then later it is going to spread. Or sometimes it can be a flat with no folded epithelium, that is what, papillary projections. And most important, microscopically we can see the papillary tumor, the outward folded epithelium with excess growth of the transitional cells. And it is anaplastic, that is undifferentiated cells are also present. Right, so that is all with the urothelial tumors. So thank you so much. We'll see in the next lesson. Hello, this is Sudharshan, and in this episode PA 2.1 and 2.2, we will talk about cell injury. So cell injury is nothing but the functional and morphologic effects on a cell when an external agent, when a cell is exposed to the external agent. So there are changes in the appearance and function of the cell when stress is applied to it, basically. And the normal cell can undergo three types of responses: adaptations, reversible and irreversible. Adaptations, that includes atrophy, hypertrophy, hyperplasia, metaplasia and dysplasia. And reversible injury, that includes intracellular accumulations, and irreversible cell injury, that includes cell death with necrosis and apoptosis. So let us see with cell injury in brief. What are the causes of cell injury? Main is ischemia hypoxia, that is the crucial factor. Ischemia, reduced blood flow to the tissue. Hypoxia, reduced oxygen delivery. And then physical agents, any injuries, chemicals and drugs. Then microbes like bacteria, virus, fungi, Then we can have nutritional deficiencies, vitamin, mineral deficiencies. Then aging, with age also it can happen, or it can be physician induced. Next, coming to the, yes, let us see with respect to ischemia, hypoxia in a bit detail. So if we see here the mechanism, ischemia, hypoxia, so because of less oxygen delivery and blood flow, energy also is less. So ATP generation will be less. Because of that, three things. One, decreased phospholipid synthesis, increase in cytosolic calcium, and generation of ROS, reactive oxygen species. Yeah, and when there is increase in cytosolic calcium, in the cytosol, calcium is more. Then increase in mitochondrial calcium, in the mitochondria it will be more. And two important enzymes, phospholipase and protease. A is always cleaving action, so cleavage of phospholipids, protease for the proteins. Proteins here in the sense cytoskeleton, the support structures of the cell, that will be affected. So because of phospholipase and protease, we have membrane damage. And membrane damage is also because of reactive oxygen species that cause lipid peroxidation. And because of membrane damage, it becomes more permeable. Whatever substances are there in the cell, all those will come out. Yeah, like the enzymes is there, myelin figures will be seen morphologically, and three important nuclear changes. Pycnosis, increased basophilic clumping, karyohexis, distribution into fragments, and karyolysis, nuclear dissolution or destruction. Now let us see the differences between reversible and irreversible cell injury. So reversible cell injury, when the cell is exposed to injurious agent or any external agent, it can come back to normal. But in irreversible, it is not possible. The mechanisms are important. So whatever the ischemia, hypoxia I have discussed, that is nothing but the irreversible cell injury. In the reversible, there are three important mechanisms. Damage to the pumps, that is sodium, potassium and calcium H plus pump. And then we have decreased protein and ATP synthesis and lactic acidosis. So here decreased protein synthesis because of cytoskeletal injury, decreased ATP as I already told because of ischemia, hypoxia. Then damage to the pumps, sodium, potassium, ATPase. Normally 3 sodium coming out of 2 potassium. Then calcium H plus exchanger. Normally calcium enters the cell with exit of H plus. And hydropic swelling is there. So cell will be enlarged because of water deposition. So blebs, 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 they are nothing but intracytoplasmic inclusions which are very weak. Right, and intracellular lactic acidosis. Again, because of anaerobic glycolysis, normally the dead end would be pyruvate to acetyl-CoA. Instead of that, lactate is generated. So PFOR enzyme will be defective there. And if we see the morphology in the reversible and irreversible, mitochondria, amorphous densities will be deposited. Presence of vacuolations will be irreversible. In membranes, very important, we are going to see myelin figures. And along with blebs, blebs in reversible cell injury. Irreversible, we have the breaks and blisters. If we take rough endoplasmic reticulum that bears the ribosomes, in reversible cell injury, ribosomes are scattered. Irreversible, total damage to RER. Then lysosomes undergoes autophagy or self-eating. Okay, autophagy in reversible. Irreversible, it is swollen and ruptured. Then cytoskeleton, it is aggregated or it is tightly bound in reversible. Irreversible mein it is broken or disrupted. Nucleus, basophilic stippling, that is the clumped chromatin, we see in reversible. Irreversible, I said that 3 changes: pycnosis, karyohexis and karyolysis. And now finally briefly about reactive oxygen species. So we know reactive oxygen species are the free radicals which are combined with the oxygen. So in the macrophages it will occur. So one side we have oxygen converted to superoxide, NADPH to NADP plus, and enzyme is NADPH oxidase. Yes. And then we have superoxide, that is O2 minus. Then SOD, superoxide dismutase. So it accepts an electron to become H2O2. Then chloride is added to it. That becomes hypochlorous acid. That along with superoxide will destroy the microbes. But here important is Fenton reaction. Just one change, instead of hypochlorous acid we have iron, Fe, first two letters. Iron, so reduction occurs. Ferric, that is Fe plus 3 to Fe plus 2. That is the Fenton reaction. Yes. So anyway, that is briefly about the reversible and irreversible cell injury. So thank you so much. We will see in the next lesson.